Right. Good good morning to all. But today's topic is diabetes, the lifestyle modification in diabetes mellitus. You all know diabetes basically is a non-communicable disease, and these are mostly lifestyle diseases because they are due to the lifestyle mechanisms which disturb the metabolism and many other things inside the body system. I'll be covering this particular topic under the following heads: introduction, definition, epidemiology, risk factors, etiopathogenesis, clinical presentation, diagnosis, screening, and of course, lastly, the complications, right? So, as far as introduction of the topic is concerned, diabetes was firstly described as the passing of large amount of sweet urine before Christ 1500 years ago. The name diabetes was given by Greek physician Athens in AD 200. Later, mellitus was added. In 1921, insulin was discovered by Banting and Dr. Best, before which diabetes patients used to die of ketoacidosis. What I'm trying to say here is that Banting and Best they invented or discovered insulin, which actually helped us in treating this particular disease. Oral hypoglycemic agents came into use in 1950. Historical, if at all we want to see something, 250 before Christ, Apollonius of Memphis coined the name diabetes mellitus, siphoned to pass through. Thomas Wills in 1975 added mellitus to the word diabetes. In 1869, Paul Langerhans, a German medical student, discovered islet cells in the pancreas. In 1910, Shapley Schaffer of Edinburgh suggested a single chemical was missing from the pancreas. He proposed calling this chemical as insulin. So this is how name insulin was brought in 1910. 1922, Leonard Thompson became the first human to find out successfully treatment of the diabetes using insulin. So 1922 onward, actually we started treating diabetes in right sense. In 1921, Frederick Banting and Charles H. Best successfully purified insulins from a dog's pancreas. Then in 1923, first Nobel Prize for insulin was given. 14th November of every year is celebrated as Diabetes Day because Frederick Banting was born on that particular day. That is the significance, that is the historical aspect. Now let us find out what is diabetes. As you can see the diagram here, basically it is the pancreas which is responsible as a gland. As a gland, of course, it has got number of things from where insulin is produced and ultimately utilized for the body. Diabetes mellitus is a chronic condition that is characterized by raised glucose levels, that is called hyperglycemia. So whenever there is a raised glucose level in your body, it is called diabetes. It's a chronic disease caused by inherited or and acquired deficiency in production of insulin by pancreas or by ineffectiveness of the insulin produced. Such deficiency results in increased concentration of glucose in blood, which in turn leads to damage of many of the body's systems, especially blood and vessels. It is a multi-system, multifactorial, multi-hormonal disorder. It is slow, silent, and sweet killer. Can you see the diagram here? Diabetes, a disease basically from womb to tomb. बच्चा पैदा होने से लेकर के मरने तक डायबिटीज से सफर करता है. वर्ल्ड सिनेरियो क्या है इस प्रॉब्लम का? The diabetes is an important public health problem One of four priority non-communicable diseases targeted for action by world leaders. Globally, an estimated 422 million adults were living with diabetes in 2014 compared to 108 million in 1980. The global prevalence of diabetes has nearly doubled since 1980, rising from 4.7% to 8.5% in adult population. One in every 11 person is diabetic in India. 1.5 million deaths are caused by diabetes. Diabetes is a major cause of blindness, kidney failure, heart attack, stroke, and lower limb amputation. This diagram shows basically the distribution of diabetic cases among the world population. As far as Indian scenario is concerned, diabetes prevalence is 8.7%, which is increasing day by day. More worrying, diabetes is India's fastest growing disease. 72 million cases recorded in 2017. Figure expected to nearly double by 2025. What an alarming situation. India has become diabetic capital, they say. It is a growing challenge in India with estimated 8.7% diabetic population in the age group of 20 to 70 years of age. The graph itself is self-explanatory. Risk factors. Now, as far as risk factors are concerned, can be divided into two types. One is modifiable, and of course, other one is non-modifiable. When we talk in terms of modifiable factors, those which can be changed, those on which we have control, those which we can prevent, like alcohol, urbanization, obesity, high fat diet, stress, sedentary lifestyle, dietary fibers, malnutrition, viral infections, and chemicals. Another non-modifiable group जो हम बदल नहीं सकते, we cannot change our age, we cannot change our gender, and of course genetics and family. These are non-changeable, that's why called non-modifiable factors. Risk factors. It is uncommon in infants and children. Diabetes mellitus is found mostly frequently in person over 40 years of age who are obese and who have a family history of diabetes. Sedentary lifestyle is a very important cause. Family history plays a very big role. If parents had diabetes, you are more likely to get it. Obesity, overweight, if you have high blood pressure, unhealthy diet. So these are basically the factors which are called risk factors. Now, as far as classification of diabetes is concerned, we can classify it to type 1, type 2, and IGT, gestational diabetes, or others. Type 1, which was previously known as insulin dependent or juvenile or childhood onset. In this, what happens? Insulin is either not produced in body or destruction of insulin secreting beta cells of pancreas results in hyperglycemia, or genetic factors results in one third of susceptibility to type 1 diabetes mellitus. In type 1, environmental factors like viral infection, mumps, coccidioides, retrovirus, rubella, sometimes stress stimulates secretion of counter-regulatory hormones and modulates immune activity. Nitrosamine found in smoked and cured meats, coffee, bovine serum albumin also play a very big role. Pathogenesis of type 1, basically genetic, HLA, DR3, DR4, oblique environmental and viral infection playing its role. Then autoimmune insulitis, beta cell destruction takes place, severe insulin deficiency is caused, and type 1 diabetes mellitus is generated. Now, if we talk of type 2 diabetes, commonly called non-insulin dependent or adult onset. Here what happens? Ineffective use of insulin. It is present, but ineffective use. Insulin resistance syndrome, IgT, low HDL, cholesterol, central obesity, microalbuminuria, increased CRP, uric acid. It's caused because of insulin resistance. In that particular syndrome, there are accompanying factors. Central obesity leads to insulin resistance. Physical inactivity plays a very big part. Overeating, eating of refined food, style of eating food, BMI more than 25 kg per meter square affects middle age and elderly population. Can you see this individual? How unhealthy diet practices it is? The obesity, central obesity, it's speaking at itself. It will lead to heart disease, hypertension, osteoarthritis, obstructive sleep apnea, hyperlipidemia, etc. Coca-Colaization. This is how the age and generation has got into this particular web. McDonaldization. McDonald basically whatever they sell, they are junk food, all full of calories and energies, leading to obesity. This is what is called McDonaldization. Physical inactivity, so in all practices, affects basically lungs, produce less oxygen, skin, lack of nutrients lead to unhealthy skin, muscles and joints. When you do not use your muscles, you lose muscle mass, so you gain weight easily and of course become weaker too. Your heart muscles grow weak. The stomach can cause complication like constipation. Bones go into osteoporosis, and other organs, of course, affected are kidney and eyes. Right. So this is how physical inactivity leads to various kind of factors. If you think in terms of pathogenesis of type 2 diabetes mellitus, beta cell defects, which is genetic in nature maybe, but environment and obesity affects it. Abnormal secretions, insulin resistance, both these things add to relative insulin deficiency in the body, beta cell exhaustion, and ultimately leading to type 2 diabetes mellitus. So this is how pathogenesis goes on. Now, if we want to compare between type 1 and type 2 diabetes, type 1 onset under 40 years, while type 2 onset above 50 years. Duration, type 1 develops within weeks, type 2 develops months and years. Body weight normal or low in type 1, while type 2 is generally obese. Ketonuria present in type 1, no ketonuria is seen in type 2. Autoantibodies can be seen in type 1, no autoantibodies will be seen in type 2. No diabetic complications at diagnosis, but in type 2, by the time you diagnose, 25% complications are common. No family history in type 1, but family history present in type 2. Other autoimmune diseases present in type 1, autoimmune diseases may remain absent in type 2. Rapid death if not treated with insulin in type 1, while in type 2 there is no rapid death. So this is how it differs from each other. Pathophysiology of diabetes mellitus, lack of insulin leads to decreased anabolism, secretions of glucagon, cortisol, and catecholamines. They are affected, increased catabolism. So, decreased anabolism and increased catabolism are the main factors. Now, decreased anabolism leads to what? Hyperglycemia, which leads to glycosuria, which leads to osmotic diuresis, and ultimate salt and water depletion leading to death. So, this is how decreased anabolism works, while increased catabolism leads to glycogenolysis, lipolysis, glucogenogenesis, hyperketonemia, and of course diabetic ketoacidosis. So these are the conditions which lead to death later on. Another factor which we see is gestational diabetes mellitus during pregnancy. Now, this is a temporary condition, occurs in about 6% of pregnancy. Recognition is essential as offspring are at risk, mostly type 2, but maybe type 1, diagnosed through prenatal screening. IGT, oblique impaired glucose tolerance or impaired fasting glycemia. Now, what is this? Intermediate at risk group with diabetes mellitus and normality. इन दोनों के बीच में होते हैं, ना डायबिटिक में आते हैं ना नॉन डायबिटिक में आते हैं, इनको इंटरमीडिएट रिस्क ग्रुप बोलते हैं. These are at increased risk of heart attacks and strokes, defined only after oral glucose tolerance test is carried out. How do we diagnose? Diagnostic criteria for diabetes are symptoms of hyperglycemia and a random plasma glucose 200 or more than that. Three cardinal symptoms of diabetes mellitus are polydipsia, means excessive thirst, खूब सारी प्यास लगना. पॉलीफेजिया मतलब एक्सेसिव हंगर यानी कि बहुत ज़्यादा भूख लगना. पॉलीयूरिया फ्रीक्वेंट यूरिनेशन मतलब बार बार पेशाब आना. So these are the three main cardinal symptoms of diabetes mellitus, and other symptoms include, of course, polydipsia, polyphagia, lethargy, stupor. In eyes, if you want, it's blurred vision. Breathing, basically smell of acetone. Gastric symptoms, nausea, vomiting, abdominal pain. Urinary symptoms, polyuria, glycosuria. Respiratory, if you want to see it, means small breathing, that is hyperventilation. And definitely, the systemic point of view say there is a weight loss. So these are the main symptoms which you see. Diabetes is basically well known because of its complications. A person doesn't die of diabetes, but person dies of complications. The first and foremost is microvascular oblique neuropathic complications. Impaired vision, renal failure, peripheral neuropathy, autonomic neuropathy, GI problems, postural hypertension, foot ulceration. Macrovascular, myocardial infarction, TIA, that is transient ischemic attack, stroke, and claudication. I hope you understand all these languages. In first, second year of clinical practice, you must have been taught about these things. Now, diabetic retinopathy, retinal changes related to diabetes. Diabetes mellitus is a major cause of blindness in adults. 20 to 74 years accounts for about 12 to 2400,000 newly blind persons every year. So diabetes is a big cause of blindness. Affects almost all type 1 diabetes after 20 years and affects minimum 60% of type 2 diabetes cases as far as retinopathy is concerned. What do we see in diabetic retinopathy? It's a progressive irreversible vision loss. Very important thing to understand. Progressive irreversible vision loss. Pools of blood or hemorrhages on the retina of an eye are visible in this particular case. Diabetic retinopathy, nephropathy. Diabetic nephropathy shows glomerular changes in kidneys of diabetes leading to impaired renal function. High risk for foot infections, as the figure indicates. Duration of diabetes अगर है ज़्यादा, increased age है, smoking करते हैं, decreased peripheral pulses, decreased sensation will lead to injuries, deformities and pressure of areas. ठीक ना, helix of foot ulcers, progression of events, how it takes place, soft tissue injury, injury not sensed because of neuropathy, infection takes place, sustains, drainage, swelling, of course redness, and which ultimately leads to gangrene. And these are high risk factors. Of course, you sometimes have to amputate the foot. Atherosclerosis, about 2 out of 3 people with diabetes die of heart disease. 2 to 4 times higher risk for strokes. These are all known factors. Damage to the nerves due to hyperglycemia. Most common complication, various types of neuropathies occur. sensory motor polyneuropathy, autonomic neuropathy, all these things are self-explanatory. Criteria for diagnosis of diabetes: you have to first take plasma blood glucose testing. Fasting plasma glucose 126 or more milligram per deciliter, or fasting is defined as no caloric intake for at least 8 hours. फास्टिंग का मतलब होता है कि कम से कम 8 घंटे पहले कैलोरीज कुछ भी लेना बंद कर दो और उसके बाद टेस्ट कराइए. अगर ये 126 या उससे ज़्यादा आता है तो यू आर हैविंग डायबिटीज. 2 hours post prandial sugar should be 200 or more than that. If it is there, oral glucose tolerance test के दौरान, then the test should be performed as described by WHO using a glucose load containing equivalent of 75 gram of anhydrous glucose dissolved in water. बंदे को पिला दो, उसके 2 घंटे बाद शुगर लेवल देख लो. If it is 200 or more, naturally banda is basically leading towards diabetes. A1C should be 6.5 or more. If it is 6.5 or more, then person is diabetic. In a patient with classic symptoms of hyperglycemia or hyperglycemic crisis, a random plasma glucose more than 200 milligram deciliter is of course taken as diagnostic. इसके अलावा हम क्या कर सकते हैं? यूरिन टेस्टिंग कर सकते हैं. ग्लूकोज टेस्टिंग बाय डिपस्टिक्स. यूरिन पास आफ्टर 1 to 2 hours of meal is tested. कीटोन बॉडीज टेस्ट कर सकते हैं. टेस्टिंग डन विद डिपस्टिक्स. पैथोग्नोमिक ओनली इफ एसोसिएटेड विद ग्लाइकोस्यूरिन. प्रोटीन यूरिया देख सकते हैं. टाइप 1 एंड टाइप 2 स्क्रीन एनुअली. माइक्रोएल्ब्यूमिन यूरिया विथ ओवरनाइट 24 आवर्स यूरिन ले लो. उसमें अगर 300 मिलीग्राम से ज़्यादा आपको माइक्रोएल्ब्यूमिन मिलता है तो नेचुरली आप यू आर लीडिंग टुवर्ड्स डायबिटीज, बट इट शुड बी इन एब्सेंस ऑफ यूटीआई, राइट. तो उस हिसाब से इसको डायग्नोस किया जा सकता है. रैंडम यूरिन जनरली माइक्रोस्कोपिक एग्जामिनेशन में अगर आप देखते हैं 30 मिलीग्राम पर डे. कैटेगरीज ऑफ इंक्रीज्ड रिस्क फॉर डायबिटीज. प्री डायबिटिक्स, fasting glucose 100 milligram to 125 milligram. impaired fasting glycemia बोलते हैं इसको. और 2 घंटे के बाद में अगर खाना खाने के 2 घंटे बाद या 75 ग्राम ओरल ग्लूकोज टॉलरेंस टेस्ट किया है आपने, और उसमें अगर 140 मिलीग्राम से ऊपर आपको मिलता है, 140 मिलीग्राम से 199, तो भी हम उसको इम्पेयर्ड ग्लूकोज टॉलरेंस की कैटेगरी में ले आते हैं. अगर आपका A1C 5.7 से 6.4 के बीच में है तो भी आप इम्पेयर्ड ग्लूकोज टॉलरेंस के लिमिट में माने जाते हैं. The biggest question is whether diabetes is preventable in spite of all these things what we have studied. Yet it is preventable. There are 3 steps, as we know: primary prevention, secondary prevention, and of course tertiary prevention. Now how do we go for primary prevention? Go for physical exercise, dietary habits change करना है, maintain weight, avoidance of sweet foods, lot of dietary fibers to eat. These are the strategies which should be adopted at the population level, right? And adults aged 18 to 64 should do at least 150 minutes of moderate intensity aerobic physical activity throughout the week. So if you are doing 150 minutes per week, definitely you are doing good physical activity. You have balanced diet. Balance is the key of life as far as these things are concerned. If you are not balancing your activities, definitely you will not be able to prevent diabetes. So for high risk individuals, what needs to be done? Screening of diabetes or pre-diabetes. Testing should be considered in overweight or obese जिनका BMI 25 kg per square meter से ज़्यादा है, who have one or more of the following risk factors. इन सब में स्क्रीनिंग करना जरूरी है. कौन कौन? फर्स्ट डिग्री रिलेटिव विद डायबिटीज, स्क्रीनिंग करना पड़ेगा. हिस्ट्री ऑफ सीवीडी, स्क्रीनिंग करना पड़ेगा. हाइपरटेंशन अगर 140/90 से ऊपर है, जरूर स्क्रीनिंग की जाए डायबिटिक के लिए. HDL कोलेस्ट्रॉल लेवल लेस देन 35 और ट्राइग्लिसराइड इज मोर देन 250, गो फॉर दिस टेस्ट. फिजिकल इनएक्टिविटी काफी ज्यादा है, ऑलवेज लुक फॉर स्क्रीनिंग ऑफ डायबिटीज. हाई रिस्क रेस एथनिसिटी वगैरह वगैरह मिले तो प्लीज गो फॉर स्क्रीनिंग टेस्ट ऑफ डायबिटीज. Patient with pre-diabetics should be tested yearly. Women who are diagnosed with GDF, like gestational diabetes mellitus, should have lifelong testing at least every 3 years. ऐसी लेडी जिसको प्रेगनेंसी के दौरान डायबिटीज हुई थी, every 3 years she must get screened every 3 years. Women with polycystic ovary syndrome. For all other patients, testing should begin at age 45 years. If results are normal, testing should be repeated at a minimum of 3 years interval, with consideration of more frequent testing depending on initial results and risk status. Other clinical conditions, of course, associated with insulin resistance should always be investigated for, like severe obesity, acanthosis nigericans, etc. Now, how do we manage diabetes? ये ऊपर जो अभी हमने देखा, it was primary prevention. Now, what we are looking for and what we are actually heading for is management of diabetes, that is secondary prevention. Means now we want to go in for early diagnosis and treatment. Secondary prevention. When diabetes mellitus is detected, should be adequately treated. What is the aim of treatment? Maintain blood glucose level, prevent hypoglycemic episodes, maintain ideal body weight, avoid alcohol. Now, treatment is based on diet alone, small, balanced meal more frequently. Diet and oral antibody diabetes, diet and insulin. So there are three aspects. One is diet alone, second is diet and oral antidiabetics, and third is of course diet and insulin. Now if we want to go in for mnemonics, diabetes means D for diet, I for insulin, A for awareness, B for balancing, E for exercise, T for test and monitoring, E for education, and of course S is stress-free life. ये डायबिटीज मैनेजमेंट के मंत्र हैं, which you should understand and make people aware of these things, right? Lifestyle management, nutrition therapy, physical activity, smoking cessation, psychosocial care, ये सारी चीजें हो जाती हैं. DSME मतलब डायबिटिक सेल्फ मैनेजमेंट एजुकेशन एंड डायबिटिक सेल्फ मैनेजमेंट सपोर्ट. There are two terminology, DSME and DSMS, as we saw, right? So these are the things. It facilitates the knowledge, skills, and diabetes necessary for optimal self-care behavior and diagnosis annually for assessment of education and nutrition. When new complications arise or when transition in care is there, these things play a big role. Medical nutrition therapy. Now, if we want to go in for medical nutrition therapy, what are our goals? To promote and support healthful eating pattern and a variety of nutrient dense food is emphasized. To attain individualized glycemic, BP and lipid goals, or to attain A1C less than 7%, BP less than 140/80, LDL up to 100 less than 100 milligram, triglyceride less than 150 milligram, HDL above 40 or 50, achieve and maintain body weight goal, delay complications. For all these purposes, medical nutrition therapy is a must. And to maintain, of course, pleasure of eating also. Now, medical nutrition, what does it say? To address individualized nutrition needs based on personal and cultural preferences, willingness and ability to make behavioral changes, to provide the individual with health eating pattern. Eating pattern? There is no single ideal diabetic diet. The distribution should be individualized, keeping in calorie and metabolic goal in mind, so it may be different for different people. Variety of eating patterns are acceptable. Mediterranean diet, plant-based diet, plant-based food, low-fat diet, etc. Now, how do we say that calorie requirement per kg per day कितना होना चाहिए? Now it is calculated as 12 to 1500 kilocalories per day for women and 15 to 1800 per day kilocalories for men. Medical nutrition therapy, how does it go? If we want to give an individual, say carbohydrates, 45% of total energy intake should be given. Substituting low glycemic load food for high glycemic load. Example, whole grains, legumes, fruits and vegetables. High fiber diet, more than 50 gram per day, which is beneficial in decreasing the serum cholesterol level and CVD risk factors. Substitution of sucrose for starch by 35%. Fructose less than 12%, naturally occurring in fruits, results in better glycemic control. Limit oblique avoid sugar sweetened beverages. Non-nutritive sweeteners has potential to decrease overall calorie and carbohydrate intakes. So this is how you have to maintain carbohydrate intake. This figure shows glycemic index or rising glycemic index among the various eatable food items. Potato, rice, honey, they have more glycemic. They are having more glycemic index. Less glycemic index is pulses, fruits, especially apple, guava, etc. So this is how we should think in terms of giving. All green leafy vegetables are useful in diabetic diets. Salad is one of the most important ingredient of the food which should be taken care of. Medical nutrition therapy, now if we want to talk in terms of proteins, 1 to 1.5 gram per kg body weight or 15 to 20% of total calorie intake in individuals without kidney disease. Very important word. When we are talking in terms of protein intake, kidney diseases should be taken into consideration. If a person has a kidney disease, the protein should be 0.8 gram per kg body. मेडिकल न्यूट्रिशन थेरेपी कंटिन्यू करते हैं तो फैट 20 to 35% of total energy intake. Monounsaturated fat improves the glycemic control and lipid. Avoid the trans fat. Saturated fatty acids required less than 10% in dietary cholesterol, less than more than 300 milligram per day as per guidelines of general population. Right, saturated fatty acids required more than 10% and dietary cholesterol required more than less than 300 milligram per day as per guidelines for general population. Omega-3 fatty acids don't have any role in glycemic control. This is एक भ्रांति बनी हुई है कि omega 3 is very omega 3 is good for many purposes but not for control of glycemic nature of the food. Sodium less than 230 2300 milligram per day or have beneficial on blood pressure control. Alcohol not more than one drink for female or more than two drinks for male as there is a risk of hypoglycemia among patients on insulin therapy. Now, if we talk in terms of oils, no single variety of oil is ideal. So, my dear friends, use two or three varieties of oils. Permissible limit 300 milligram milliliter per person per month. 300 ml per person per month. Ideal oil combination of both saturated and unsaturated oil. Saturated with MUFA, PUFA ratio should be 1 is to 2 is to 1, right? The saturation of saturated MUFA and PUFA ratio should be 1 is to 2 is to 1. This shows composition of this thing. Now change your diet and change your life. This should be the motto of life when we are trying to treat or advise dietary patterns as far as students are concerned, or as far as the patients are concerned. Have two snacks mid morning and evening. Simple thing. Fruits, sprouts, boiled legumes. एक कटोरी बहुत है. With grated carrot, मूली and lime juice. Oats, ragi porridge. One small glass, 100 gram, 100 ml. Murmura, 1 katori. Roasted chana, oblique peas, 1 katori. Badam and walnuts, fistful. Now, as per your purchasing capability, you can choose things from this particular menu and go for it. What needs to be avoided? What needs to be avoided is you please avoid all sweet items like you want to eat basically gulab jamun, all type of vegetable, everything sweets should be avoided. Now, food to be avoided, of course, are seen in the diagram. That is sugar, honey, jaggery, cake, jelly, pastries. All should be avoided. Food to be avoided, those which have got high glycemic index. That is potato, sweet potato, अरबी है ना चुकंदर गाजर ये सब चीजें थोड़ा सा अगर हम अवॉइड कर सकते हैं तो ठीक है फूड विच आर ऑल्सो बेनिफिशियल्स व्हेन वी आर टॉकिंग इन टर्म्स ऑफ ट्रीटमेंट ऑफ डायबिटीज से ब्रिंजल जामुन करेला स्प्राउटेड फूड्स एंड ऑफ कोर्स नीम की पत्ती अगर हम बात करें तो these are very very important ingredients when we are trying to treat diabetes as a local therapist. And this have been years, crores of years of experience, which has actually sorted out these particular items important in controlling diabetes. Fruits to be avoided, of course, those who have high glycemic index. नारियल का पानी, चीकू, banana, dates, and of course mangoes, and lastly the grapes. They all have high glycemic index. So it will be better if these foods are avoided. And fruits which are allowed, pears, papita, that is papaya, orange, maltas, guavas, and of course watermelon. Now these are the fruits which you can take very happily. They have got little less glycemic index. So they are important to be understood in case of treatment of diabetes. Now generally the question is asked, Doctor, what do I take in breakfast? Right? So usual should be that any preparation bit of this thing thoda poha ho gaya ya you can have little bit of egg also you can have certain soya fruits plus most of the time if you really want to have sugar free items which you can take you can always eat your target should be that fasting 90 to 130 milligram percent आपका लेवल होना चाहिए your usual thali oblique plate should contain milk, curd, vegetable proteins. And what is recommended in particular thali is you must have milk and curd, of course, protein and starch and cereals, rather than having too much of starch and less of protein. Right? So this is the best of the nutritive therapeutic diet for diabetes. This figure shows the model balanced diet. Of course, plenty of water is required on day-to-day basis for your own treatment. That is, drink at least 8 to 10 glasses of water per day. In other words, I can say 2 to 3 liters per day. Yeah, alcohol. You are very fond of taking alcohol. If at all you are fond of taking alcohol, drink only one drink per day as far as women are concerned. Take maximum 2 drinks. If you are a male member, so men can have 2 drinks. Don't make it a rule. Don't make it as a recommended allowance. Yes, you may be permitted to do so, but in limits. Smoking cessation, tobacco, and e-cigarettes are promoted nowadays. Physical activity, there is no question that you should stop it. Physical activity is the crux of the treatment as far as you are concerned as a diabetic patient. Adults with type 1 and type 2 diabetes or pre-diabetes should engage in 60 minutes per day or more of moderate or vigorous intensity aerobic activities. With vigorous muscle strengthening and bone strengthening activities at least 3 days a week. Even if you don't want to do anything, at least keep 3 days in a week reserved for you for some kind of physical activity which will help you in long run and which will help you in control of diabetes. If not control, at least prevention of diabetes. All adults and particularly those with type 2 diabetes should decrease the amount of time spent in daily sedentary behavior. Don't keep sleeping here. The laziness doesn't pay. Prolonged sitting should be interrupted by briefly standing, walking after every 30 minutes. Make it a rule, even if you are sitting in an office. Flexibility training and balance training are recommended 2-3 times per week for older adults and diabetics. And of course, yoga may be included based on individual preferences. Anti-diabetic medications, I'll not be discussing more details as far as the diabetic medicines are concerned because we are basically talking in control and prevention. However, sulfonylureas, you know, magnetides, bigonides, glucosides inhibitors, and thiazolidines. These are the groups, pharmaceutical groups, or these chemicals which can be utilized for control of diabetes. Of course, you will be taught in uh, clinical medicine about more about these particular things. As far as insulin therapy is concerned, it has been on since 1921 onward. Recombinant DNA technology enabled large-scale production of human insulin has been produced now. It is available in various forms, rapid acting, short acting, and intermediate acting, oblique long acting insulins as far as these things are concerned. Why? You must know how to use insulin. Insulin is a very important part of the treatment, but you must know how to use it. Injected subcutaneously, that is number one. Delivery devices, glass syringes, plastic syringes, pen device, infusion pump, a lot many devices are available now in the market. Short acting given 30 minutes before meal. Side effects, if you take a little more, you will definitely go into hypoglycemia. Weight gain, edema, local allergy, and lipodystrophy at injection site generally takes place in the insulin. Classification: insulins are three types: short acting, intermediate acting, and premix insulins. Ultra short acting भी है, long acting भी है, और premix analogs of NPH, regular insulins, are also available. Again, I said we will not go into details of the treatment modalities here. Classification: insulin and analog preparations are available, short acting as well as long acting both, which you will be taught definitely in case of clinical medicine. Tertiary prevention. Now see, ingredient of tertiary prevention are limit the disability and rehabilitation. How do we go about that? Our main object is review patient regularly, prevent complication to occur, and if complications occur, manage and treat them. That is called rehabilitation. How to review a patient diabetes? Keep looking at his body weight and BMI. Keep doing urine analysis, glucose, ketone, and albumin. Lipid profile should be seen regularly: renal, thyroid, liver functions, glycemic control, HbA, home blood glucose monitoring, awareness of hypoglycemic episodes, like then blood pressure, smoking, eye examination, lower limb and feet. Regular attention should be paid on the factors listed above or whatever I have just spoken to. These are very important factors for observation as well as control. Diabetes, my dear friends, basically runs in families. Healthy eating habit should be encouraged in the whole family. So as you can see in this particular diagram, the family of giraffe, of course, it's a symbolic phenomena which I'm trying to show you, but family as a whole should take care of it. So let us join hands to fight disability, public diabetes. Thank you very much.